used, and it seemed to work out pretty well over the past couple of years, is I give you like a little 2-line case study, which is why another reason we're doing case studies. A little 2-line case study, you know, so-and-so has been admitted for fluid volume deficit. And then the questions, there are 2 or 3 questions afterwards related to that case study. And it seemed to work out pretty well. So I don't have all these questions mixed up. I don't have a fluid volume deficit and then a potassium question and then a calcium question. I've tried to make it so that if your brain starts thinking about fluid volume deficit, it thinks about fluid volume deficit for the first 6 questions, and then you can switch your brain off to another. Does that make sense? Mm-hmm. Kind of organized it a little bit. So that has seemed to work out pretty well the last several years, so we're going to stick to that. Okay? All right. So we ended yesterday talking about fluid volume excess, the opposite of fluid volume deficit, and I wanted to start off today talking about those, looking at the answers to those articles that I had you look at. So if you'll pull those out, the IV fluids, do you know what's hanging in Y? And the growing up with us, the fluid balance in children. So we're going to look at those real quick. Now, again, this is an older article, but I like this article because it means these kinds of things don't really, the IV fluids don't really change per se, and knowing how to identify what fluid is and why it's hanging is good. Jeff was asking me about the fluid controversy little snippet, and if they have implemented some of those changes, and they have implemented some of those changes already for fluid resuscitation. So you may see that in your, wherever you go for the OR or wherever, you may see some of those concepts. So, all right, let's look at these questions. The first one said, water makes up about what percentage of the average adult's total body weight? And it's C, 55 to 65%. And that's something y'all should have known already, hopefully, from anatomy. Okay, number 2. All of the following tightly regulate the body's water except circulation. Okay. What is the primary purpose in giving fluids in shock? Increased blood pressure. Now, we talked about hypovolemic shock yesterday. Remember, we did that little snippet on it. And again, you guys are going to go over hypovolemic shock more in detail when you're seniors, all the different types of shock, but I wanted to just kind of introduce you to that. So does everybody understand that? That our biggest thing at that point is to increase blood pressure. And we've got to correct, remember, the underlying problem. That's the biggest thing with shock, is that it's caused by something. Something happened. If it's a GI thing, we need to stop the vomiting, stop the diarrhea. Okay. Number 4, diffusion of water across a semi-permeable membrane from an area of high concentration to an area of low concentration is known as osmosis. That should be something you should have known forever. Right, high to low, high to low. What is the normal serum osmolality? 300. Which of the following complications is common to all colloids? Fluid overload. And what is an example of a colloid? What did they say in here? Albumin is an example of a... Right. Anything that is a what? It's a volume expander. They are considered volume expanders, but that is a common side effect, unfortunately, is fluid overload to those. Which of the following fluids are commonly given to correct dehydration and hypernatremia? Hypotonic fluids, right? Mm-hmm. Right. Now, was that easy to answer now, knowing that we give a hypotonic fluid for a hypertonic situation? Right. Which of the following fluids is given to pull water back into circulation from the interstitial space? Hypertonic saline? Mm-hmm. Yeah. According to research, which of the following fluids is pro-inflammatory? Lactated ringers, LR. What did they mean by pro-inflammatory? It causes the inflammatory process in the body to begin, right, doesn't it? What did they say about it? Did they say that was good or bad?
Bad.
It's bad, right? So that's why we don't do what? Why do we don't give LR for trauma patients, right, for trauma patients. Okay? Which of the following is a symptom of fluid overload? Neck vein distension. What are some other things? Kind of a review from yesterday. Fluid volume excess. Headache, neurological changes, nails are bulging, sound wet, crackles, bronchi, weight gain. What about the change in vital signs? What happens? What about the pulse? It goes in bounding pulse. The blood pressure can go up. Okay? If fluid overload is suspected, which of the following actions should the nurse take first? Discontinue the fluid. Exactly. Remember I said that yesterday, that in an emergency situation, you can stop the fluid and then call the physician. Right? We don't do that on a normal basis just because you want to. But in an emergency situation, we've got to think about the patient. It's like putting oxygen on somebody, and Ms. Walker will talk to you guys about that in the respiratory unit. Yes, oxygen is an order. It is a physician's order, and a lot of people consider it a medication even. But if you are in a patient's room and you've checked their pulse ox and their oxygen level is 80, it's okay to put a nasal cannula on them at low, 2 liters, and then call the physician to get an order for it. They may say, we'll bump it up to 5 or whatever. I would also call who else? Respiratory, and we do that all the time on the unit. And I call them on the unit before I call the physician too, because those respiratory therapists are specialized in that. And they may say, oh, this is okay, but let me stick a mask on for right now until we call the physician. So that's okay to do in an emergency. For patients receiving LR, the nurse needs to particularly monitor the patient for hyperkalemia. Right, hyperkalemia. Right. What is hyperkalemia? Too much potassium. Which we're going to talk about today. Which of the following symptoms indicates to the nurse that a patient is experiencing hypernatremia? Or muscle weakness, right? Excuse me. What is the latest trend in administering fluids during resuscitation? Permissive hypotension, right, exactly. Permissive hypotension. And why did they say that was? Remember? Why is it okay for their blood pressure to run a little bit low?
Yeah, too much fluid is bad. It said like less is more, but better than none.
Exactly, exactly. You can go, there's such a fine line during fluid resuscitation. And it's better for them to be a little low than for you to go totally the opposite problem. So, okay, new evidence suggests that limiting perioperative fluid has proven to significantly shorten post-op ileus. Right. Now I want you to pay attention to that when you go to OR. See how much fluid they actually give them. They're not giving them as much as they used to. They would give you massive amounts of fluid in surgery, and they don't do that as much anymore. So, okay. Which of the following colloids is a polysaccharide? Dextrin, right. Which of the following colloids is used to treat erythroblastosis fetalis? Albumin. And we'll talk about EBF when we do OB. Okay, and then which of the following fluids promotes all uric diuresis? Mannitol. Right, mannitol. Okay. I hope you learned something from this. It's a good article. I keep using it year after year because it's the best one I've found so far. Okay. Let's look at our fluid balance in children. Okay. You will see me throwing a lot of these out at you. I may put some up periodically online and say just an FYI, or I use these a lot for if you miss clinical with me on peds. I use these a lot because they're really, I think they're really, really good. They're really good articles. They're short and to the point, and they give you a lot of information. So, fluid balance in children. Okay, let's talk about these answers. All right, Sammy, who's 19 months old, weighs 10 kilograms or 23 pounds. He has a 2-day history of vomiting and diarrhea and is not yet toilet trained. Normally, Sammy needs how many milliliters in 24 hours to maintain fluid balance? 100 milliliters per kilogram. Okay. The younger the child, the less fluid imbalances are tolerated. True or false? True. The majority of Sammy's total body weight is intracellular. Sammy is more susceptible to fluid disturbances than older children for all of the following reasons, except his need for fluids is proportionately less than for older children. Of the following options, to most accurately assess Sammy's output, the healthcare provider should weigh a dry diaper in his wet diaper and subtract the difference. And we talked about that, right? That was one of the best ways to tell a child's output, and we're going to be doing that on peds if you come with me. All fluids inside the cells are referred to as what type of fluid? Intracellular. Water moves from an area of blood concentration of solutes to an area that has a higher level in an effort to equalize them. True. I know we talk high to low normally instead of low to high. I can see where you would put false for that. It's kind of confusing. But the thing on there is says an effort to equalize them, and that's what it's wanting to do is equalize. So it does go high to low normally. Changes in the level of solute concentration as occurs in various types of IV solutions influence the movement of fluid electrolytes between the fluid compartments. True. Which type of solution will cause a shift of fluid into the cells? Hypotonic. Which of the following is a cause of sensible fluid loss? Urination. Okay. All right, so just some things to think about. All right. We're going to start today with our electrolytes. Okay. And we're going to start with potassium. All right, where are the people who had to do potassium over break? Okay. All right. First off, let's look at this slide real quick, and then we'll get to y'all. All right, electrolytes. Do you remember from anatomy that they enter in through the diet, right? And excreted through the urine. That's the most common way that electrolyte balance occurs. We have to intake it. Now, the body does contain some electrolytes already, but for the most part, to maintain balance, we do have to it has to enter through the diet and excreted by the urine. The body does not store sodium. That's something we always have to intake. But the body does store potassium and calcium. Okay? So that's just something to remember as we're talking about our 3 different electrolytes that we're going to be talking about. Okay, potassium people. Let's talk about what you learned. Okay? Alright. People who did potassium. Where is potassium mostly found? Huh? Intracellular. Most of the potassium is intracellular. Okay? What is it used for?
Tissue excitability.
Tissue excitability. Protein synthesis. Glucose uses in storage. Okay. So, in a situation where I have hyperkalemia, and you've got to remember this. Everybody needs to really remember this because I think this is a little bit confusing for a lot of people. If I draw a potassium level, okay, I'm drawing a potassium level, and my potassium is high. Where is most of the potassium? Extracellular. It has been pulled out of the cell into the extracellular fluid. If my potassium is low, where would it be? Intracellular. Most of the potassium has been pulled into the cell. Okay? Alright, so let's review what we talked about. What does potassium do? These are some pictures that I put up. Nerve impulse conduction. We mentioned that. Nerve impulse conduction. But one of the biggest things right here, and we talked about, I think somebody said tissue excitability, specifically the heart. And you've got to remember that. With potassium, it's cardiac, cardiac, cardiac. That is our biggest thing that we have to remember. Cardiac tissue. The cardiac tissue is very, very important. Okay? Skeletal and smooth muscle contraction. Skeletal and smooth muscle contraction. Is the heart considered a smooth muscle? Yes. So the heart, we're talking about the contraction of the heart. So if we don't have potassium, if we don't have enough potassium in our system, we're going to look at this, would we expect the patient to be having cardiac symptoms? Yes, definitely. Okay. Do you remember the sodium-potassium pump? What was that? What was the sodium-potassium pump? Dust it off and kind of refresh your memory. What? Pumps the sodium out, puts the potassium in. Right, exactly. Does everybody remember that from anatomy? That's one of the things I always hated talking about. All those little things are a little bit confusing, but the sodium-potassium pump is a very important part of the body. So we do need to remember that. Okay, let's talk about hypokalemia. Now, we're going to do a little, if we have time tomorrow, we're going to do a little bit more with your, over the Christmas break homework. But okay. All right, hypokalemia. Hypokalemia is a level below 3.5 milliequivalents per liter. Now, let me tell you something, okay? The values that I tell you that we talk about in class are what I'm going to test you on. When you go to the hospital, they may be a smidge different. The reason for that is because of the way that they run the labs, the way that they run labs. So if I say potassium should be between 3.5 to 5.5, that's what you're going to go on for the test. If you go to the hospital and they say potassium should be 3.2, don't get all up in arms about that, okay? Don't call me up or text me or whatever and get all upset about it. It's the way that they process their lab work, okay? But for testing, we're going to go with my numbers. All right?
It'll be these numbers.
NCLEX should be these numbers as well. Yeah. Okay. So serum level below 3.5. Below 2.5 is a medical emergency. Below 2.5. Anything below 2.5 is a medical emergency. That means you have to intervene immediately or something bad is getting ready to happen. Okay? Now, there's a lot of causes of hypokalemia. The first one is inadequate intake. That's just a simple one. You're not taking in enough foods or supplements that contain potassium. Okay, just inadequate intake. Because remember, where do we get the most electrolytes? Through intake, through our diet, right? Okay. Use of diuretics. Specifically what type? Loop. Potassium wasting diuretics are loops like Lasix. Okay. There's a bunch of other drugs that will cause a low potassium. Steroids, corticosteroids are an example. penicillin and any of its derivatives as an example of one of things that will cause a drop in potassium. Theophylline, which is a drug to help open up the airway. Theophylline, Theophylline, Theophylline. Theophylline. Oh, airway. And chronic use of laxatives and enemas. Chronic use of laxatives and enemas. So all those medications, not just diuretics, but all those medications can cause potassium to be wasted. Okay? So loop diuretics, corticosteroids, penicillin, theophylline, laxatives, and enemas. All those can cause a waste. All right. Loss of GI fluid. We talked about in fluid volume deficit, right, are vomiting and diarrhea. Those GI symptoms. Another type of loss of GI fluid would be through suction. And we mentioned that as well. You remember how that excessive suctioning could cause a fluid volume deficit, can it? So when you're losing any kind of GI fluid, heat-induced diaphoresis, so heat exhaustion or heat stroke. Now, do you remember when we talked about assessment? What is the difference between exhaustion and stroke? Do you remember? Sweating. Exhaustion, you sweat. Stroke, sweating, you've gone past the sweating, right? Okay. All right, starvation diets. Anorexia, bulimia. Alcoholism is considered a starvation state. And you're going to hear me mention alcoholism as we go through all these different electrolytes, because what do alcoholics do and not do? They drink, but they don't eat. Exactly. If you know anybody that has an alcohol problem, that's their biggest problem, is that they drink too much and they don't eat enough. So alcoholism is considered to be a starvation state. Have you ever heard of pica? P-I-C-A. You eat things that are not normal, that are not non-nutritive things. Paper, clay, ice can be considered chronic. I know everybody likes to eat ice, but chronically eating ice. I mean, like all the time. Like, I'm worried about one of my little stepdaughters because she eats ice all the time. She'd rather eat ice than food. We had a patient last spring, and I felt sorry for the little girl, but I wish everybody, all my students for the next 50 years could see this because it's so rare. She came in with a intestinal blockage, and she was, I can't remember, she's like 13, 14, intestinal blockage, and they just thought it was a regular old blockage, and they went in to do a lap to try to unblock her, and she had a 4-pound hairball in her gut. She'd been eating her hair. And it was just the ends. She wasn't pulling out the hair and eating it. She would chew on the ends. Have you ever seen people do that all the time? It had gotten so bad that it had formed a hairball. We had the pictures of the hairball. They actually had to remove that part of the bowel. It was so bad because that hair had gotten tangled up. It was huge. Yeah, it was huge. I mean, it was huge. 4 pounds worth of hair. And the surgeon said it was the nastiest thing he had ever smelled. Because it had been sitting in there and rotten and binding to all of that stool. So I felt so sorry for her because that was definitely a psychiatric issue. I mean, she had eaten enough to get to that point. So those situations, though, are called pica. Okay, P-I-C-A. Now, pica, the pica form where they eat clay or dirt, which is a fairly common type of pica, that is especially troubling or problematic for potassium because clay and dirt binds to potassium and renders it inactive. So that is a problem. And when do you see a lot of pica? Pregnancy. Pregnant women, you'll see them eat chalk, like chalkboard chalk. We've had patients that come in, they eat starch. So we had a pica child that would eat detergent, like powdered detergent. So, and she wasn't trying to kill herself or anything, even though she was doing a pretty good job because her esophagus was just totally excoriated, eaten up. But she was eating powdered detergent, and I said she was 9 or 10. So, and why was her mother not noticing that there was powdered detergent on all the time? But there was a lot of issues there. So pica is definitely a problem. Okay, high glucose levels. Patients who are diabetic, especially when they have what we call DKA. And DKA stands for diabetic ketoacidosis. And you guys haven't talked about diabetes yet, but what that means is that the blood sugar levels are extremely high. And remember, what did we talk about? What would that also cause?
Dehydration.
Dehydration, right. A fluid volume deficit. Because glucose is another solute. Sodium is the one that we were really talking about, the most serious, but glucose is another solute as well. So diabetic ketoacidosis. And we're going to mention that again when we do acid-base balance. Because you see this right here, acidosis. That kind of tells you right there what kind of acid-base imbalance it will be. Depends on the patient. If it is a patient who is pregnant, and we'll mention that this summer, diabetic ketoacidosis can occur with levels just in the 200s. But these patients are usually 400, 500, 600. I had a patient one time when I was still nursing at Rowan that was over 1,000. The blood sugar level was over 1,000. Of course, they were comatose, but they can get really high. Yeah, they're very high. Okay. Increased secretion of aldosterone. Increased secretion of aldosterone. There's a lot of chronic conditions that will cause that to occur. Adrenal tumors is one of them. There is a condition called Cushing's disease. Have you heard of Cushing's? Cushing's disease. Where the body retains a lot of fluid. They're cushy. I always think of Cushing's disease. They're cushy. They're squishy. 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 And then diabetes insipidus, and we mentioned that with fluid volume deficit, didn't we? Because what does that cause? An increased amount of urination. So they're urinating it out. And back to the DKA, back to that diabetic ketoacidosis, that's what occurs with DKA. Their blood sugar levels are so high that they are urinating so much. Now, one thing you're going to learn about with diabetes is there's the 3 P's of diabetes. Did y'all talk about that? Have you talked about that before? Polyuria, polydipsia, and polyphagia. That's how you can know somebody's blood sugar is high. That's usually how they diagnose people. Because they come in, they say, I'm thirsty all the time, all I can do is drink. I'm hungry, but I don't seem to be gaining any weight. I'm eating all the time, and I'm urinating all the time. And these people will get up several times during the night, go to the bathroom. They go all day long. So polyuria, polydipsia, polyphagia, the 3 P's of diabetes. So polyuria is what causes hypokalemia. We're losing it. Okay? So these are just some of the causes. Now, you know me, I like pictures. So here's a picture of a patient or a man who has hypokalemia. This is Walt. This is Walt. So Walt is telling us the signs and symptoms of a patient who has hypokalemia. Okay, so if you're trying to remember the signs and symptoms of hypokalemia, you can think of a sick Walt. Okay, and basically with hypokalemia, everything starts to slow down. Everything gets very sluggish. A is alkalosis. Right now you don't need to worry about alkalosis because that's not on this test, but you do know that alkalosis is an increased level of base in the blood. Okay? Alright, so when we're thinking about things slowing down, he has shallow respirations. Shallow respirations. Irritability or anxiety. Now, another thing that I think one thing that makes fluid electrolyte balance so hard, so difficult for people is that so many of these electrolyte imbalances have the same symptoms. So as we go along, I'm going to say this is one that everything has, so you don't really need to worry about it as much. And this is something that's really unique to this electrolyte. Okay, so that's how you're going to be able to help remember some of these. So when you're thinking about potassium imbalances, those shallow respirations are very important. Irritability is common with all the electrolytes or anxiety. Okay? Confusion and drowsiness is important. Remember, everything is slowing down. So confusion and drowsiness. Muscle weakness. Because remember, what is potassium? What do we say to begin with? What is potassium good for? Muscle contraction. So if we don't have enough potassium, what's going to happen to the muscles? They're going to get weak. What do people complain about a lot? Leg cramps, painful leg cramps. Okay, and then everybody says, "Oh, eat a banana." Well, you know, bananas are great, but if your potassium level is really low, it's going to take a whole lot of bananas to get your potassium level up. So weakness, fatigue, leg cramps. The muscles are flabby. Look at his arms. You see how they're kind of flabby? So the muscles are you just have no strength in them. They're just so weak you have no strength. EKG changes or arrhythmias, we don't need to worry about. We're not talking about the rhythms. I'm not teaching you rhythms. That's something you learn when you're a senior. But I do want you to know that if you stick your stethoscope on a patient to listen to their apical pulse, when they have a potassium deficit, you're going to hear an irregular heartbeat. It's going to be very irregular. Okay, it's not going to be a regular loved up. It's going to be at a regular rate. They may be a little tachycardic, so that's an opposite of the everything slowing down. They're lethargic. If the level is low enough, and you remember me saying that below 2.5 is a medical emergency. Remember me saying that? If it gets to 2.5 or below, they may end up comatose. So it may go from lethargy to coma if it's not corrected. So potassium levels are low. That's an extremely important thing to fix. Okay, and then the D sign, the little arrow that's going down, is just showing that they may have an ileus, they may have nausea and vomiting. See how on him he says his little stomach and heart says wake us up when it's over. They just kind of get sleepy. They get sleepy and flabby and lethargic, and nothing's really working. Because remember that potassium is so important for muscle contraction. So if we don't have enough potassium, everything just kind of goes hot. Okay. All right. So what kind of nursing diagnosis might we see with a patient who has a potassium deficit? Think about some of these things that are going on. These are some risks for injury. Why? Because of the muscle weakness, they're at risk for falling. confusion, lethargy, they're just sleepy. Why an ineffective breathing pattern? Because of the shallow respirations. Decreased cardiac output because of the irregular heartbeat. Remember, the smooth muscles are not contracting. Constipation. We talked about the fact that the intestinal mobility slows down to the point where they may have an ileus. Does everybody understand that an ileus it's totally stopped? That's a bad thing. You cannot let the bowel totally stop. If you have an ileus, that is, again, an emergency. We've got to fix that. Altered nutrition, maybe if it's a poor dietary thing, if it's related to intake and fatigue. We'll talk about that. Okay, so what do we do for patients who have hypokalemia? All right, mild to moderate. Now remember me saying that with fluid volume deficit, we can replace it orally if the what? Thirst is intact, deficit is mild, and they can swallow. Right, exactly. Very important. And that's, again, important to remember with these electrolytes. We can replace it orally if it's mild to moderate hyperkalemia. So dietary-wise, what types of foods are adequate with potassium? Salmon, okay. Orange juice, fruit.
Green leafy vegetables.
Green leafy vegetables, your broccoli, your greens like collards and kale and all those greens. Tomatoes. Bananas, of course. Nuts, whole grains. Now, I don't know if you knew this or not. Does anybody here like black licorice? Black licorice? Okay. Some people really do. Some people really don't. But some people really love it. If you've got a patient who has a low potassium level, they are supposed to avoid black licorice. Because black licorice, if eaten in large enough quantities, will cause hypokalemia. So, it's just something if you know somebody like black licorice. All right, oral potassium. It comes in a lot of different forms. Has anybody given a potassium tablet yet to their patient?
I gave a liquid.
You gave liquid tablets. They're huge, aren't they? Look like horse pills. The liquid's orangey colored. Okay. Comes in a lot of different forms. Depends on the patient. Now, those potassium tablets, I don't know if you were told this by your instructor, but those potassium pills, if you're ever giving a patient one and they have a hard time swallowing it, they do melt. So if you take those tablets and you put it in a medicine cup and you just drip just a couple of drips of water on, not a lot, just a couple of drips, it will actually dissolve out, and then you can put it in applesauce. It still tastes nasty, but it does help because those things are huge. So we've got K-Dur. That's a form. K-Lite. Micro K. And then they've got Slow K, which is like a slow release form. So those are some different types of potassium. You always dilute liquid potassium. If you're giving it liquid form, the orange liquid, it's really kind of syrupy. You always dilute it. They should never drink it straight. So always, you can put it in juice or something like that. Is that what you did? Yeah, put it in. Oh, it still tastes horrible, yeah. The Slow K is the tablet form. It's just a slow release. But the K-Dur or Micro K, liquid potassium.
If it's the Slow K, it's like the extended release, you're not supposed to dissolve it.
You can dissolve it, you can't crush it. Right, and that's something very important to remember. You never crush potassium. So dissolving it, what that does is it keeps the little particles still together. So you'll see it's very grainy when you dissolve it with that little bit of water. But when you crush, it crushes those little grains open. Okay, so very good point. You never crush it, but you can dissolve it. So that's just a little trick of the trade to remember, because those things are huge. They're huge. Okay, so we talked about liquid potassium. You always dilute it. Okay. If it is given IV, especially in severe cases, okay, in severe hypokalemia, you can replace it IV. It's usually in with another fluid. So you'll see like D5.5 with 20 milliequivalents of KCl. They may give it up to 40 milliequivalents of KCl in an IV fluid. But it's given in an IV at a drip form. You never, 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 never push potassium. You don't. You never push it. It will stop the heart. Okay? This is just an interesting side note. This is not something I want to test you on. I don't know if you knew this, but potassium is the last of the 3 drugs that they give during execution by lethal injection because it stops the heart. They give 3 drugs. That's the 3rd one because it stops the heart. They push it in. And so that's why we are not going to do that, right, with our patients. So if you, that's something just to tuck in the back of your mind. And they say, I don't know how they know this because the patient's dead by that point, but they say it's painful. They say that kind of death is very painful. So I think one of the drugs that they give to them is a sedative or something, and a painkiller, and then they push the potassium. So,
Because it burns the veins.
well, I think it's internally too, inside the heart. I think it's very painful. So, and a lot of people would say, well, they're criminals, they're being put to death, but still, I mean, humanely, right? But it is very, very, very painful. So that's just something to kind of tuck in the back of your mind. You never, ever, 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 ever push potassium, okay? If you learn anything from me, that's one thing I want you to learn. Now, when you're giving potassium IV, if you've got a patient who's getting D5.5 with 20 of KCl, okay? One thing they're going to complain of after a couple of days is their veins are starting to burn, the site burns, because it is very excoriating to the veins, okay? So it is not uncommon for patients who have an IV with potassium in it for them to have another replacement IV. So you always check the site. If the site is getting red or puffy or irritated, or you know what, even if they're just complaining and you look at the site and it looks fine, but they really saying it's hurting, you just need to say, you know, we need to change that IV site because it will cause trouble. We will have problems with that vein. So you really want to do that. Has anybody ever had potassium through their IV before? And it is horrible. It burns. It does burn. So you really, really want to be careful about that. Okay. All right. Any questions about hypokalemia? All right, let's talk about hyperkalemia. All right. 5. Serum level above 5. So 3.5 to 5 is our level of potassium. 3.5 to 5. Anything greater than 6.5 is a medical emergency. Anything less than what is medical emergency? 2.5. So anything less than 2.5, anything greater than 6.5 is a medical emergency. Okay, now, why we have excessive intake, so over-ingestion of potassium-rich foods. I'll tell you where people get into the most trouble with hyperkalemia is salt substitutes. Okay? If you've got a patient who needs a restricted sodium diet because they have heart problems and they have to restrict their sodium and they say, oh, I'm going to use Mrs. Dash instead of salt. But they use it on everything. That can cause a hyperkalemic state because salt substitutes have too much potassium in them. So you still have to teach them to limit their use. They can use it instead of sodium, but they need to limit. They don't put it on everything. Okay? All right. Decreased excretion. The opposite of Cushing's disease is Addison's disease. Okay, Addison's disease is an adrenal insufficiency. So where the potassium is, we have decreased excretion. What about renal failure patients? Do you think that would be a problem? One of the reasons that people need dialysis so much is, when we mentioned that with fluid volume excess, is also the electrolytes, because they start to build up in the blood because they can't be excreted out. So renal failure patients. All right, massive tissue trauma. Massive tissue trauma, because as, say you're in a wreck and you have totally damaged your body. You have quite a bit of trauma. What happens to those cells? What do they do? What causes the bleeding? What happens? The cells burst. The cells rupture, and they release all the stuff that's inside out into the system, out into the body. And where do we say that most of the potassium is? Inside the cell. If the cell bursts, right? If they were in a car wreck and those cells are damaged and those cells burst and it releases all that potassium out into the body, then it's out in the serum, and it would be considered a hyperkalemic state. Now the last 5 things I've got on there are in bold. You see that? You can kind of tell. The reason for that is because they're considered relative hyperkalemia. Relative hyperkalemia. What that means is there was never a true body increase of potassium. It occurred because something else happened. Okay? In other words, the others, you did something. Something was wrong with the body to cause it to increase. You took too much in. You couldn't excrete it out. This is when it occurs because of other things. So metabolic acidosis, hyperkalemia goes along with metabolic acidosis. Metabolic acidosis is the problem. It's just that hyperkalemia occurs as a side effect of that. A GI bleed. A GI bleed. Why would a GI bleed, you think? Because of the burst cells. The burst cells.
What did you say? It was not a true what?
Body increase, not a true body increase. So it occurs because of movement of the potassium from intracellular to extracellular. You could actually think the tissue trauma could be too, yeah. They don't list it that way in the reading, but I would say, yeah, it could be. Because it kind of goes along with the same concept of the cells first. Use of digoxin. Now, dig is not a medicine that we talked about earlier, but dig is one of them. What about those others that we talked about? Overuse of corticosteroids, for example. Remember we talked about those? Okay, overdose can cause hyperkalemia. And then insulin deficiency can cause hyperkalemia. So all those are just problems where hyperkalemia is a side effect. All right, now do you remember a sick Walt? Mm-hmm. Okay, let's look at what the man looks like with hyperkalemia. Okay. So if things slow down with hypokalemia, what would you expect things to do here? Speed up, increase. So we have muscle twitching. Muscle twitching. Remember earlier we had muscle weakness. Weakness, right. They were kind of flabby. Remember he had flabbiness. Here they're twitching. And if not corrected, it can lead to paralysis. Now, we're not just talking about the muscles of the body and the heart. We're also talking about the muscles around the lungs. They can actually, their heart can actually stop, and they can go to respiratory arrest because of the fact that the muscles are so overactivated that they can cause them to go into a respiratory arrest. All right, irritability and anxiety. Remember, that's one of those I said it goes kind of along with everything else. Okay. Decreased blood pressure. I know we just said that everything increases, but the blood pressure is the one thing that will go down. It's an irregular, slow heart rate with a decreased blood pressure. Again, the heart rate and rhythm is irregular. We're not going to talk about the type of rhythm it is or what you would see on an EKG. Just know that it is irregular. Now, with hypokalemia, we said that the bowel slows down and we have constipation and could lead to an ileus, right? In this situation, we have cramping, hyperactive bowel sounds, and you may see diarrhea. Okay. Okay. Let's talk about these last couple of slides and then we will take a break. All right, nursing diagnoses, just the basic ones. Risk for injury, again, decreased cardiac output. So all these things are pretty much the same, except the diarrhea. Okay. All right, let's talk about interventions. All right, so dietary again, we are going to restrict foods that are high in potassium, especially foods that have hidden sources of potassium like our salt substitutes. That's the big thing. Salt substitutes, really something to remember. Again, most people think salt substitute, they think sodium. But it is high in potassium, so you got to be really careful. So, especially salt substitutes. Okay, medication. All right. There is orally a medication called Electrolyte. Nastiness. It can also be given as an enema. Called Electrolyte. If you've never experienced it, anybody ever experienced the results of Electrolyte? Mm-hmm. Lord help out. It is an exchange resin. That's what it does. It's an exchange resin. You can give it orally, which I would hope that you would never have to do because it's nasty, or as an enema. It looks like tar. It looks black and thick and tarry. Think about resin. Think about a tree resin, how it's sticky. You know, resin as a tree resin is sticky. Mm-hmm. What this does is it exchanges sodium with potassium. Exchanges sodium with potassium. And excretes the potassium out in the resin in the stool. And it is everywhere. If anybody ever seen meconium stool of a baby, how it's sticky and it's hard to get off, imagine that in massive form.
What is it? It secretes potassium out?
It exchanges potassium and sodium. It takes that potassium that is exchanged and it sticks it in this tarry resin in the body, and then you poop it out. You poop this resin out. So there's black, tarry poop everywhere. Everywhere. And you cannot get anybody clean. I mean, it is, have y'all experienced that? Oh, it's horrible. Everywhere. But it works. It works really well. Really, really well. Sorry. Okay, another thing you can give IV for hyperkalemia is calcium gluconate. Okay? You can give calcium gluconate. What calcium gluconate does is it antagonizes it like a sibling. It antagonizes the potassium on the myocardium, on the heart muscles, and decreases the irritability of the heart muscle. It antagonizes the potassium, the effects of potassium, the high potassium is having on the heart muscle. You know, it's kind of making it twitchy and giving you all those irregular rhythms. It antagonizes it. And it causes it to stop and slow down.
But is the potassium ever released?
However, it does not promote the loss of the potassium. So it is a short-term intervention, and they only use calcium gluconate during a code. If you've got a patient who has had a cardiac arrest and it's due to a high potassium level, they're going to give the calcium during that moment to help the code situation. It's not going to get rid of the potassium. So the problem's going to return if they can't get it out of the body. But at that moment, it's going to help you get the patient back. Okay? Now, what they will give, what they can give, is regular insulin. Regular insulin and D50 to shift the potassium back into the cell where it's supposed to be. They give regular insulin and D50 to shift the potassium back into the cell. They give both. They give both at the same time. Because if you give too much of the insulin to a non-diabetic, their blood sugar's going to drop. So you have to give the dextrose, the D50, to keep that from occurring. So they're given together. Shifts it back into the cell. All right? And then to keep it the way it's supposed to be, they're going to give a potassium wasting diuretic. Then they'll start Lasix or Bumex or Diureal. Some of those medications that will help to get rid of what's left. So you can imagine you've got all this potassium floating around. You give the regular insulin, you give the D50, it causes the majority of it to shift back into the cell, but there may still be some floating around extra because they can't get it all back into the cell. So they're going to give a diuretic to get rid of what's left. Does that make sense? Mm-hmm. So it's kind of a process. It's a process. Now, if you've got a patient who's not in severe shape, they're hyperkalemic, maybe they're 5.2. Okay? So they're hyperkalemic but not severely hyperkalemic. They may just give the diuretic and not worry about all the other stuff, because that way it can get rid of the potassium that is in the system, in the serum. So hopefully you can intervene before you have to end up giving the calcium gluconate, the insulin, and D50 and all that. Okay? All right. I'll let you go on a break, but when you come back, I have more. What do we know about calcium? Where is it located? Well, no, in the cell. Do we know? Do we care? ECF, it's more equal. It can be either or. Calcium was one of those that there's almost an equal amount in the ICF and the ECF. What's calcium do? What's it important for? Why do we care about calcium? Blood clotting, bones, muscle movement.
Relays nerve springs.
Nerve impulse conduction. Activates enzymes. All right.
Helps the blood vessels go to blood throughout the body.
Okay, helps the blood vessels. Okay, so let's look at our picture. Maybe. I put the shark up here for the teeth, because he has pretty teeth. So yeah, it assists in building strong bones and teeth. And I think most people when they think of calcium, that's the first thing that they think about. They forget about all the other things that it does for us. And calcium is very important for other things, the blood especially. Okay, so that it facilitates blood clotting. If you didn't hear that, it facilitates the blood clotting. This is a picture of a nerve. It's essential for nerve transmission, the impulse transmission. It's important in skeletal and cardiac muscle contraction. Skeletal and cardiac muscle contraction. And it activates certain enzymes. So those are the things that it's really important for. Activates certain enzymes. All right, so calcium, we're going to talk about calcium loss and then decreased calcium intake. So when we're talking about decreased calcium, why is it decreased? So the first thing is calcium loss. Now, let's look at our level, 8.5. So serum level below 8.5 milligrams per deciliter. Okay, why? The first one is hyperphosphatemia secondary to renal failure. Now, one thing I want to remind you, we're not going to talk about phosphorus, but remember me saying that calcium and phosphorus have an inverse relationship, right? So if calcium is low, we would expect the phosphorus to be high, and opposite. If the phosphorus is low, the calcium is high. So even though we're not talking about it, you can kind of guess what it would look like in the situation. Okay, so renal failure. And when we said renal failure, the bad thing about renal failure is that all of those electrolytes and fluids start to build up in the system. All right, acute pancreatitis. Acute pancreatitis. Bone metastasis. Bone metastasis. Diarrhea. Especially conditions that cause chronic diarrhea, like Crohn's disease. Bowel resections. Because calcium cannot be absorbed by the bowel. And immobility can cause a loss of calcium. Now there is a substance called, I don't have it up here, but it's important to know. There is a substance in blood transfusions, in blood units. I don't know if you've ever heard this before. When you're transfusing blood, you have to be very careful because there is a substance inside blood bags called citrate. Citrate. Citrate acts as a preservative so that blood remains stable. The problem with citrate is that it binds to calcium, making it inactive, rendering it inactive. So if you are transfusing multiple units of blood to someone, say you've got a trauma patient who comes in and they need 6 units of blood, that is going to cause them to have a hypocalcemic state because the amount of citrate that's in those blood bags that's being transfused to those patients It's kind of one of those side effect things. They need the blood, but you also have to treat the hypocalcemia that's going to be affected or be caused by that. Okay, so that's something else to remember. Okay. Right, exactly. Well, no, bone metastasis in cancer. Cancer metastasis to the bone. Right, cancer metastasis to the bone.
What about people who have parathyroid?
Parathyroid, the PTH, parathyroid, right? Hypoparathyroidism, where there's an insufficient or lack of parathyroid hormone. Yep. Loop diuretics are another cause. We really look at loop diuretics for potassium, but they do cause an excretion of calcium as well. So loop diuretics are another problem. So you've got your parathyroid, hypoparathyroidism, loop diuretics. There's a lot of different causes of it. So calcium loss or decreased calcium intake. Okay, decreased calcium intake. If you have a situation where the albumin is low, hypoalbuminemia, which is a big long word, from a lot of different things, malnutrition, cirrhosis, chronic illness, all those things. A lack of albumin causes the calcium to not be absorbed and function. It's a malabsorption state. And then, of course, diet. You know, there's a lot of people out there that just don't like milk or cheese or yogurt or anything like that. I know I bought a gallon of milk yesterday, and yesterday afternoon, by evening, Ben had drunk half of that gallon of milk. But there are some kids that won't drink it at all. You know, we go through gallons a week. Some conditions where there's a GI malabsorption, if you have a malabsorption syndrome, it will absorb the calcium that's into it. Now, talk about what these patients look like. I don't have a nice little picture for calcium, but we can talk about what they look like. Neuromuscular signs. There are two signs that you really need to know that are indicative of a hypocalcemic state. The first one is Trousseau's sign. And the second one is Chauvet's sign. Both of those are indicative of hypocalcemia. What Trousseau's sign is you take a blood pressure cuff, put it on the arm, you inflate it to about 20 millimeters of mercury above what their systolic blood pressure has been running. So let's say their blood pressure has been running 180 over 60. Then you would inflate the blood pressure cuff up to 200 and lock it in place where it doesn't come automatically down. You leave it there for about 3 to 4 minutes, and what will happen is the hand where that blood pressure cuff is will start to spasm. It'll be like a palmar flexion spasm, and it'll start doing this number. So it looks kind of crippled. Their hand just kind of turns in and it spasms in, and it's because of the pressure. That's called Trousseau's sign, and that's a positive sign of hypocalcemia. Okay, it's a palmar flexion spasm of the hand. Chauvet's sign, what you do is you tap the facial nerve right in front of the ear. You tap the facial nerve right in front of the ear. and it will cause a twitch or a muscle contraction on that same side of that face. So their face will do like this number. It'll kind of twitch or spasm.
Where's that location?
Right in front of the ear. Right in front of the ear. You tap that facial nerve right in front of the ear. And their face will kind of spasm. It'll twitch and spasm. Okay. These are just two of the signs of what they call tetany. Have you ever heard of the word tetany? T-E-T-A-N-Y. You know, and tetany is an umbrella term. So tetany is the umbrella. Underneath the umbrella is Chauvet's, Trousseau's. There are other things under that umbrella, like hyperactive deep tendon reflexes. Hyperactive deep tendon reflexes. They will complain of numbness and tingling in their hands and feet. Numbness and tingling in their hands and feet. And they will start to hallucinate. Now, if those signs of tetany are let go long enough, they will eventually cease. Okay? So under the umbrella of tetany, we have Chauvet's, Trousseau's sign. We have tingling and numbness in the hands and the feet. Hallucinations, hyperactive deep tendon reflexes. All those things are underneath that umbrella. Tetany, T-E-T-A-N-Y. Okay? Now, cardiac-wise, they're going to have a weak, thready pulse, kind of like with our hypokalemia. They have a weak, thready pulse. And hypotension. Again, if it's prolonged, just like with your hypokalemia, they can go into cardiac arrest. Okay, so weak, thready pulse, hypotension, cardiac arrest can occur. Bless you. Another thing that is very serious that you need to keep in the back of your mind with hypocalcemia is laryngospasm. L-A-R-Y-N-G-O spasm. S-P-A-S-M. Now, I'm kind of glad Holly's not here today since she just had her thyroid taken out, because you will see hypocalcemia very commonly with thyroid removal, thyroidectomies. The first code that I ever witnessed was a laryngospasm from a thyroidectomy, and their airway closes off. They cannot breathe. And I remember going into that room and Dr. Whitaker taking, the first code I ever watched is The Miracle I Survived. She was coding. I mean, she could not breathe. And there was no way to get an airway down because of the swelling from the spasm. Mm-hmm. And literally what he did is took a scalpel and sliced her neck open where the scar was from the thyroidectomy and stuck an airway in. And there was blood everywhere. I mean, all over his glasses, all over the walls, all over the ceiling, just like in the movies. I mean, that's exactly what it looked like. But that is how serious it is, because when you have a laryngospasm, the swelling from the spasm closes off their airway, and there's no other way to get an airway down. So it's very, very serious. Thyroidectomies, I think a lot of people write them off as, oh, they're in and out, no problem. I get very nervous to this day still with thyroidectomies. You really have to watch them closely. And a lot of people will come back from a thyroidectomy with calcium IV because of the fact that removal of that thyroid affects the calcium. So very serious, very something really, please pay attention to that. Okay, renal. Renal failure, of course, can cause low serum calcium levels with renal failure. Their bowel sounds are hyperactive. They're not slow like with hypovolemia. They're hyperactive. They may complain of cramping and diarrhea. Okay.
What did you say about renal?
Renal failure causes low calcium levels. Okay. Now, bone fractures. I've got this hip bone up here. Bone fractures, you see how it's broken, are very common due to, and we're going to talk about bone problems with hypercalcemia as well. In this situation, what happens is the bone starts to demineralize. Okay, so it thins out. It starts to demineralize. You may see holes in the bone. It becomes spongy, like with osteoporosis. You see holes. So it looks like Swiss cheese because it's demineralizing, and they will fracture very easily. Now in children who have problems with this, with hypocalcemia, it retards their growth. So their growth, they tend to be very small. We do a lot of growth hormone in children who have hypocalcemia. Patients who have hypocalcemia complain of bone pain, a lot of bone pain. Okay. And then the last thing I want to talk to you about, or about assessment, the last kind of sign and symptom, is that they have, remember we talked about calcium is important for clotting? They have an increased risk for bleeding and bruising. Bleeding and bruising. So patients with hypocalcemia, you'll see with all the different bruises all over their arms and legs, everywhere. They bruise very easily. It's like those little old women, you know, who knock up against something just easily and then they have a huge hematoma from it. Okay? So they bleed and bruise very easily. They have brittle hair and nails as well. We got 5 more minutes. Let's see how much we can get through here. Okay. Nursing diagnosis, pretty much the stuff that we've already talked about. Cardiacs you're going to see with everything that we talk about because of different causes, but risk for injury, of course, altered nutrition, knowledge deficit. Okay, let's talk about what we do for patients with hypocalcemia. How much calcium do you need a day? Do you know? Anybody know? Off the top of their head? 1,000 to 1,500 milligrams a day. That is the right now. That's the current recommendation. I did hear the other day on the news. I can't remember if it was. I think it was on the regular news.
Yeah.
That they are actually telling people that multivitamins are not as important anymore as they used to be. Did y'all hear that? Yeah. Because they're finding so many people that get enough dietary-wise, and it's just overdoing it a little bit. But if you know that you are lacking calcium, you need 1,000 to 1,500 a day. And where's calcium available? Where do we know dietary-wise? Milk and milk products, orange juice, salmon. We mentioned salmon earlier. Tofu. If anybody eats tofu, I've never had it before. Heard it's disgusting, but some people like it. They're getting better at putting calcium in things for children, like their fortifying cereal. with calcium. There's calcium fortified cereals because they know that not a lot of children. I had a friend growing up who didn't eat milk on her cereal. She poured orange juice on her cereal. But I've heard that that's kind of a common thing, so I don't know. Okay. There are 3 types of oral calcium, the way that you can get calcium orally, besides intake, medication-wise. Okay? The first kind is what they call bisphosphonates. You've heard of those? I'm going to get ready to put them forward. Okay, bisphosphonates. They inhibit bone destruction. Okay, they inhibit bone destruction. Preserve bone mass. And it prevents fractures. Now, you've probably seen some of these bisphosphonates advertised on TV. One of them is Fosamax. You heard of that one? Fosamax is a bisphosphonate. Boniva. Heard that one? Boniva. What's her face? I can't remember her name. She does the commercial for Boniva. Sally Fields used to, and then there's another one now.
Blair, yeah, she played in
It's an older lady with white hair, and they say, break your leg, and she said, I used to love to hear that, but have y'all seen that one again? Let's see, Actonel. Have you heard of Actonel? That's one. Reclast. Actually, that's EL. And Reclast. So those are some examples of bisphosphonates. And what they do again is inhibit bone destruction, preserve bone mass, and prevent the fracture. Okay. You can give calcitonin, straight calcitonin. Calcitonin can be given nasally as a nose spray. It slows bone loss. They give calcitonin a lot for women who are in menopause who can't take estrogen. The women who can't take estrogen but maybe in menopause are women who've had breast cancer or other female cancers, specifically breast cancer. There's a link they're finding between breast cancer and estrogen. So women who can't take estrogen, and estrogen protects the bones against osteoporosis. Okay? So if they can't take estrogen, then they're kind of up the creek. So they give them calcitonin. It can be given orally, but it can also be given nasally. Not orally, IM, so Q or intranasally. You see it as a spray. It does. It prevents bone loss. Or slows bone loss. Let's do slows bone loss. So it's not going to take it totally away, but it does slow it. And then you can take oral calcium. You can actually take calcium supplements. Now, if it is severe calcium, if it is severe hypocalcemia, you can give calcium gluconate IV. When did we also give calcium gluconate? For hyperkalemia, didn't we? Because we were trying to get the potassium. Remember, we were trying to get the potassium back in, and we were trying to. It was aggravating it, so it was help agitating it like a sibling. You can actually give calcium gluconate IV. You have to be careful though, because again, it's acting on the heart like that potassium was, and it can cause it to slow down too much. So you've got to be really careful if you're ever giving calcium gluconate. Okay? what we're gonna do is finish up with our calcium and do